Hey everyone, we are going to get started with today's webinar, Emergency Contraception Panel Discussion. My name is Kelly Cleland. I'm a researcher at Princeton University and the director of the American Society for Emergency Contraception. I'm a consultant to ARHP for this program, and I'll be moderating today's webinar. Before we begin, I'd like to share with you how you can receive continuing education credits for this webinar. In order to receive credits, you must complete the post-webinar evaluation. About an hour after the conclusion of this webinar, you'll receive an email from Caitlin Borsiewicz, ARHP's Communication and Education Associate, with a link to the evaluation. Your continuing education certificate will be generated upon completion. For those of you who participated in our previous webinars earlier this year, please take a moment during the evaluation to share how you've incorporated what you learned during those webinars into your practice. This information helps ARHP ensure that we're meeting your professional education needs. Thank you in advance for your time and feedback. And we'll have a Q&A session at the end of the webinar, but please feel free to submit questions into your chat box as they arrive during the webinar, and we'll address questions at the end. This is the disclosures of our planning committee. And now I'd like to introduce James Trussell and Beth Cruzy, today's panelists. James Trussell is Senior Research Demographer at the Office of Population Research at Princeton University and Honorary Fellow at Edinburgh University. He is the author or co-author of more than 350 scientific publications. In addition to his research on emergency contraception, he maintains the EC website nottolate.com. Beth Cruzy is a certified nurse midwife with many years of clinical practice and research experience in midwifery, well-woman gynecology, family planning, and abortion care. She was the state of Washington's first representative to Midwives for Choice and currently holds a seat on the National Advisory Committee for Clinicians for Choice. Their full bios are available on ARHP's EC webinar webpage. We're thrilled to have two such leading experts in EC with us today. And I want to make a note that this presentation may include information that is not on FDA-required product labels. This presentation has been peer-reviewed by our panel, and this program was funded through an independent education grant from Efficacy. At the conclusion of our program today, participants will be able to discuss the latest research and regulatory decisions about EC efficacy and weight, discuss the mechanism of action of EC, repeated use of EC, and the latest recommendations for providing hormonal contraception after EC. In addition, you'll be able to address frequently asked patient concerns and questions about EC. This webinar builds on EC webinars offered by ARHP earlier this year. We gathered some of the most pressing questions from providers and patients, and we'll discuss these questions with a focus on the newest research. First, we'll present existing research, any recent regulatory responses, new research and guidelines, and finally, messages for your patients. Throughout the webinar, we'll have audience polling questions to give us all a sense of how these issues are playing out in your practice. And this is the first patient question that we're going to address. I weigh 180 pounds. Will EC still work for me? And this is our first poll. So please choose the answer that best fits your experience. And Caitlin is going to give us some polling technology. In the past year, how many patients have asked you about whether EC would be less effective for them because of their weight? No patient has asked me about this. 1 to 10 patients, 11 to 25 patients, and more than 25 patients. So just take a quick minute to answer this question based on your experience in your practice. Okay, and here are our results. So this is interesting. So it looks like about 60% of people are saying that no patient has asked about this, and about a third are saying 1 to 10 patients have asked about it. So this is really interesting because this is obviously a big issue in EC research. It's coming up a lot in discussions among providers, but it's interesting to hear that people are saying that their patients are not asking about this a lot. James is going to start on this section and talk to us about what we know about EC efficacy and weight. Go ahead, James.
Thank you very much, Kelly. Well, this is what we have known now for some time since Anna Glaser published this paper in Contraception in 2011, and it clearly shows that levonorgestrel, there's a rapid decrease in efficacy with increasing BMI, reaching the point where it appeared to be no different from pregnancy rates expected among women not using ACPs at a BMI of about 26 compared to 35 for UPA. So what was the regulatory response? There was a European label change for Norlevo, which is the same as Plan B one-step, 1.5 milligrams of levonorgestrel. They said in the label it was less effective for women weighing 75 kilograms or over, and it was ineffective for women weighing 80 kilograms or over. Then in 2014, after examining other data, the data that led to the label change came from HRA Pharma, and then when they looked at data submitted by World Health Organization, they removed the warning, and then in 2016, the FDA determined that the data are conflicting, which is true, too limited to merit a change, and encourage further studies by manufacturers. But I don't believe that there are going to be any further studies by manufacturers. I think we have all the data we have, and my own personal opinion is that the HRA Pharma data, which showed a decrease in effectiveness for levonorgestrel, are correct, and the WHO data are not. Now, what else do we have? That's, of course, using a hard endpoint of pregnancy as an outcome. The WHO study was finally published. It's on the Contraception website under Articles in Press. But now we have some more data. These are new, but these are pharmacokinetic studies, and the first one has only 10 women. 5 women of normal BMI and 5 women who were obese. And what was measured here is just the concentration levels of levonorgestrel, and compared 1.5 milligrams of levonorgestrel in normal BMI women with 1.5 or 3, that is a single dose or a double dose, in obese women. And so what was found here is that if obese women took a normal dose, then the concentration of levonorgestrel was 50% lower, but if they took a double dose, then it was equivalent. So this might suggest that a double dose might make sense. But doubling the dose of levonorgestrel may not be financially feasible for many women. And of course, the pharmacokinetic studies don't measure endpoints directly related to efficacy, like ovulation or pregnancy. And one older study showed that half the dose of levonorgestrel in normal weight women still disrupted ovulation, and other factors at work besides serum concentrations we don't know. But based upon this information, the next UK guidelines, at least in draft form, are recommending a double dose for obese women. So let's,
Do we have one more slide on that?
it seems to have skipped it.
Oh, okay.
Can you go back?
There we go.
So there we go. So in summary, the IUD does not lose effectiveness regardless of weight. So it's always, the copper IUD is always the most effective option, both for normal weight and obese women. Offer the most effective methods that would be IUD is first, and then ulipristal acetate for all women, with levonorgestrel as a third choice for obese women. But if options are limited, don't deny ECPs due to body weight. That would be our summary. Beth, do you have anything to add?
I do not. Thank you very much, James. I think that that last point is really the whole thing about emergency contraception is the best last chance, and whatever we have as the best last chance, we should help women have access to. Thanks.
Then let me turn it over to you for the second section.
Thank you.
Yep. So our next question is, if I use Ella, can I start my new birth control method right away? This has been a source of widespread confusion and new research and new guidelines, so that's why we wanted to get into this. Our next polling question, in your practice, what do you recommend for patients who use UPA-EC and want to start an ongoing hormonal contraceptive method? So here are the options. Would you recommend that she take UPA and start her new hormonal method immediately, otherwise known as quick starting? Take UPA and start a new hormonal method 5 days after use of UPA. Take UPA and start the new hormonal method 5 days after last unprotected sex. Don't take UPA if you want to start a new hormonal method. And finally, I don't prescribe UPA-EC. So please take a minute to choose which answer best reflects your regular practice. Okay, so we have about a third of people who are saying that they recommend quick starting hormonal methods immediately after taking UPA. Another about third are recommending that a woman take UPA and start a new hormonal method 5 days later. And then about another third don't prescribe UPA-EC. So Beth, why don't you go ahead and tell us what we know about this topic.
Fantastic. Thank you so much, Kelly, and thank you, James. I'm really honored and delighted to join both of you in this opportunity to clear up some of the implications of the more recent research. It seems like the more we learn, the more questions arise. So I think that the information that we've gotten about the effect of UPA on ongoing contraception and the effect of ongoing contraception on UPA has been pretty confusing, and this is a great opportunity to clear some of that up. This is the regulatory response to new data, and for many years we were really excited about starting hormonal contraception just as soon as possible after emergency contraceptive pills, and when Ella came on the field we did the same thing. Until very recently, the general consensus was that we wanted to do that so that the person at risk could be protected by her ongoing method as soon as possible, knowing that the ongoing method is more effective than emergency contraceptive pills. But last March, the FDA approved a change to the Ella label, which now says that a woman who wants to start ongoing hormonal contraception should wait to start the method at least 5 days after using Ella. And we'll get to the root of this in the next slide. But briefly, the concern is that since ulipristal acetate, or Ella, is an anti-progestin, basically, following it up quickly with hormonal contraception that contains a progestin could block Ella's ability to inhibit ovulation. All right, let me see if I can get this to move. There we go. Whoops. Sorry. Little delay. So here's the background. Sharon Cameron did a study in May of 2015, was published investigating whether or not Ella would interfere with the efficacy of OCs, and found out that in fact it didn't. But in a different study, Vivian Brakey, just a little bit later, considered whether following UPA with hormone combination or progestin-containing contraceptive would counteract the effect of UPA. And they did in fact find that in cycles where women started a placebo pill after taking Ella, there was only one ovulation cycle within 5 days. In this study, that was 3%. This was a small study. There was only 41 women that completed the entire trial. But when UPA was followed by a desogestrel oral contraceptive pill, ovulation occurred within 5 days in 45% of cycles. So the desogestrel very dramatically counteracted the effect of the ulipristal acetate to delay or prevent ovulation. So normally, if a woman comes to a clinic after unprotected sex and takes ulipristal acetate, we assume that she's using the most effective oral emergency contraceptive, and that will probably be successful at delaying ovulation. But if that same woman then quick starts a desogestrel pill, there's a good chance it will counteract the effects of the UPA, and she might be right back where she started in terms of her risk of pregnancy from that active unprotected sex. So what we don't know is a lot. The results of that small study are quite compelling, but we're left with some important outstanding questions. One thing we don't know is whether or not these results even apply to other hormonal contraceptive pills. We don't have a desogestrel only pill in the United States, so we can't even be sure whether these results apply to pills that are available here. Desogestrel actually is better at blocking ovulation than other types of progestins like levonorgestrel or norethindrone or norgestimate, so maybe the effect on UPA might be different with a different pill. We don't know if this applies to Mirena or the implant or Depo. And finally, given that we don't have the answers to these questions, how do we go about weighing the competing risks? What's more important, the potential loss of efficacy of Ella if we quick start a hormonal method, or the potential loss of the opportunity for a woman to get started on a new effective method right away? So given that the evidence on this question is still evolving, we all find it challenging to integrate this information into clinical practice. So we're going to go ahead next with some guidelines that have been developed given what we know now. The CDC has just published the selected practice recommendations for contraceptive use just in July. And they included information on these most recent studies, which is great. The timing was really excellent for this. Basically, hormonal contraception should be started no sooner than 5 days after taking ulipristal acetate or Ella. That non-hormonal methods such as a copper IUD can be started right away, and especially because the copper IUD is an extremely effective method of emergency contraception. So if that's used, no other EC is needed. It's the best there is. It's the Cadillac. And then for methods that require a visit to a provider, such as a levonorgestrel IUD, an implant, or a shot, there may be a concern that the woman may not be able to return to the office or clinic 5 days after taking the UPA or the Ella. The CDC guidelines state that for these methods, providers can consider offering the method the same day, but they must weigh the risks of the potential loss of efficacy with the future risk of pregnancy posed by not starting an ongoing method. And I would add that there's also the consideration that even under ideal circumstances, there can be up to a 20% failure rate of emergency contraceptive pills. or they can be completely ineffective depending upon whether or not the LH peak has already passed. So if the EC isn't effective at preventing pregnancy and you've put in an IUD or an implant, you have to look at that as well. And then finally, the CDC recommends using a barrier method of contraception or abstaining from sex for 7 days after Ella, just as for most methods, New Start. The American Society for Emergency Contraception has developed a more nuanced set of recommendations. And I think these are extremely helpful in real life, in the complicated lives of our clients and our clinical encounters. So it's a little bit more of a complicated algorithm as well, and it involves some additional considerations that are very pragmatic. The ability to access Ella or ulipristal acetate, that's very real. It's unfortunate, but it's real. Not all pharmacies carry it. Not all women have access to a pharmacy. Not all clinics stock it. So that's, you know, right off the bat. And then what about the patient's cycle day? If she knows her usual cycle length, what cycle day she's on, and you can look at that and the timing of sex and consider whether she's at greater risk for pregnancy from the active intercourse that just occurred or from future active intercourse. And that's important. Then you can assess whether or not she's more concerned about the pregnancy from the sex that just occurred or from future sex. You can find out if she's interested in ongoing contraception and whether or not she's likely or able to return for a follow-up visit in a few days, if she'd prefer a provider-dependent method. And then finally, and this is fairly clear, if she needs emergency contraception because she missed or was late for her pills, patch, or ring, then that gives you an easier answer, actually. So approach number one, which would be the first choice option when the patient is able to access Ella and she's at high risk for pregnancy from previous sex based on her cycle day and her timing of unprotected sex. She's more concerned about pregnancy risk from a very recent act of unprotected sex than about sex in the future. If she feels okay about using a barrier method, that's a reasonable thing for her to be able to wait in future until her new method is effective. She's interested in ongoing contraception, and she's likely or able to return. And she doesn't need EC because of missed or late pills, patch, or ring. So this is just a review of that, a little bit of a graphic here. You'll notice that the American Society for Emergency Contraception uses 5 days after last sex instead of the 5 days after taking Ella, which is what the SPR says. And the reason for that is that since sperm are only viable for 5 days, if you just count from the day that the last unprotected sex occurred, you're going to be safe. So you don't have to wait an additional number of days. I mean, if they're the same thing, if sex, just occurred that day, then it's going to be the same. But you can actually start a method a little bit sooner if you know the sperm have already died by then. And then the other thing is with providing a method to start 5 days after the last unprotected sex or starting with the placebo pills, if you feel like your client, if that's not going to be confusing to start at the bottom of the pack and then go to the top of the pack, depending upon your client, again, this is where nuance in clinical practice comes on. You don't want your clients to be under the impression that they should be starting with the bottom row of their pill pack every cycle. So that there's a little something there. I think that's what we need to cover there. And then the second approach would be if Ella is unavailable or If she needs EC because of Mr. Late Pills patch or ring, that's fairly obvious. If she's also at relatively low risk for pregnancy from previous sex, more concerned about risk from future sex, and she's interested in ongoing contraception and wants to just go ahead and get started right then. The other thing is if she's breastfeeding and she doesn't want to discard her breast milk for 24 hours, which is recommended for using Ella or UPA. So this is the schematic for approach number 2. Again, with the levonorgestrel IUS, provide only if reasonably certain that the patient is not pregnant. In considering the risk of failure of emergency contraception and the possibility of a concurrent new pregnancy with an IUD, I think we can't fail to remember that. The SPR does have a very clear little guideline for how to be reasonably certain that a woman is not pregnant, and most of those criteria don't really go along with meeting emergency contraception in the first place. So I would just advise a word of caution with that. This is patient messages, just the take-home points that you wouldn't want to use any progestin-containing contraceptive at the same time or quickly start after ulipristal acetate. At this point, we don't know whether they will counteract the Ella. So we're holding off on that for more information. If you can balance concerns and realities about what the level of risk is depending upon when in the cycle the unprotected sex was and the likelihood of being able to protect in the future. And then, of course, if emergency contraception is needed due to Mr. Late Pills, we would recommend levonorgestrel. That sums up this portion. James, do you have anything to add for this?
Just to about breastfeeding and UPA. What's recommended in the among Europeans is to discard breast milk for 5 days, and that's not true.
Yeah.
So that's a long time, 5 days.
Yeah.
So
yeah, that's
express and throw it away.
Yeah. Do you know what the difference was between why the CDC decided that 24 hours was sufficient?
No, I don't.
I don't either. I remember noticing the difference, but I don't know what it was based on. So yeah, that's obviously territory for further investigation. Thank you so much for pointing that out.
One of the many areas of confusion in the world of EC research and guidelines. I wanted to just clarify, based on a question that came in, when we talk about LNG EC, that's Plan B one step, next choice, after pill, that's all of those kinds of levonorgestrel EC that's available in the U.S. over the counter, just to clarify that if anybody wasn't sure. And just as a reminder, if you want to send in a question, go ahead and put that into the chat box, and then we're going to respond to most of those questions at the end of the webinar. Our next topic is how EC pills work. And this is something that may come up from time to time with your patients. Certainly comes up a lot in the media. It's come up in the Supreme Court. There is a lot of confusion about what EC is and how it works. So we are going to talk a little bit about this. We have some new research that's pretty interesting on this topic. So our next poll, in the past year, how many patients have asked you about how EC pills work and particularly whether EC causes an abortion? So here are choices. No patient has asked me about this. 1 to 10 patients have asked. 11 to 25 patients. And then finally, more than 25 patients have asked about how EC pills work and particularly whether EC can cause an abortion. So just take a minute to answer that question. Okay, so we've got about a quarter of people saying your patients are not asking about this, and about half are saying 1 to 10 patients are asking. So it's interesting, this may be an issue that is more important in the media than it is with your patients, but it's something that everybody should be able to address fluently with your patients. So James is going to go ahead and cover what we know about how EC pills work.
Well, here's a summary of what we know, that levonorgestrel EC prevents or disrupts ovulation, but it works only before the LH surge has begun. Once it has begun, then it will not work, and there's no effect after fertilization or implantation. So here we have one study about UPA. Does it interfere with human embryo implantation in utero? So we have 10 embryos in each group, one exposed to UPA, the second not exposed to UPA, and there was no statistical difference between the number that attached, 5 in one group and 7 in another. So it does not interfere with implantation. Here's a second study. Does it have similar efficacy before and after ovulation? So on the left-hand side, we have UPA given before ovulation. This was a much larger study, 364 women there, and then UPA given after ovulation, 329 given there. 78% of pregnancies were prevented in the first group, and only 36 in the second group. So in the first group, the pregnancy rate was lower than expected, showing that UPA worked. And in the second group, it was the pregnancy rate was the same as expected, showing that it had no effect whatsoever. So the latest evidence shows that EC pills, both levonorgestrel and UPA, work primarily and perhaps exclusively before ovulation. If EC pills prevented implantation, they would be more effective than they are. Pregnancy begins at the successful implantation of a fertilized egg in the uterus. No EC methods have been shown to work after implantation. And that's, Beth, do you have anything to add to this section on how they work?
No, the only thing was, and I know you're going to talk about this a little bit more later, but I think it's worthwhile mentioning here in terms of, you know, any potential worry about abortifacient effect. That really large pharmacovigilance study that was published in 2014 of 1 million women after taking ulipristal acetate, showing much evidence for safety after failure of use in terms of you know, live births without anomalies and no increased rate of spontaneous abortion or anything like that. So I think that's additional support for safety after failure.
Okay, thank you. All right, so now we're going to move on to our next question. This is about IUDs as EC. This might come up in your practice if you offer the IUD, copper IUD as EC, but you might find that patients prefer the levonorgestrel IUD. So the question is, I know that the copper IUD is an option for EC, but I'd rather use Mirena. Can this kind of IUD be used as EC? I'm going to let Beth go ahead and talk about what we know about this topic.
Thank you. Let's see, let me activate my mouse again. There we go. What we know about the copper IUD is that it's been used for over 40 years. It's as close to 100% effective as pretty much anything can be. One of my constant mantras is there's nothing in this world that's 100% effective, but this gets really close. And the copper IUD does work at any point in the cycle. It's only approved as emergency contraception under the guidelines, so it mustn't be used more than 5 days after ovulation. So I just want to, point out that when we're looking at the copper IUD as EC, we want to keep that in mind that that we're still using those guidelines because, well, that's another story. But it's not frequently used, and I think one of the reasons is that there's access issues, there's also awareness issues, there's also a proportion of women that really would rather have a levonorgestrel IUD. They'd rather use a Mirena than a copper IUD. So despite the fact that the copper IUD is an extremely effective emergency contraceptive method, people don't necessarily want to continue using that as their ongoing method. They'd rather use a levonorgestrel IUS. Unfortunately, we don't have data yet, not enough data, to recommend the levonorgestrel as an emergency contraceptive. It doesn't have that immediate effect on sperm that the copper ions do, or at least as far as we can tell right now. So we do have some really exciting new data. In one recent study, 188 women were enrolled in this study, and they were offered either a copper T or a combination of levonorgestrel emergency contraceptive pills with a levonorgestrel intrauterine system. The majority of women, 64%, chose the latter option, and really great, there were no treatment failures in either group, so nobody got pregnant. There was, however, one pregnancy, not only a pregnancy, but an ectopic pregnancy in the levonorgestrel group. The thought is because of historical data around this particular patient, she had had several episodes of unprotected sex earlier in the cycle and had also used emergency contraceptive pills on at least one occasion earlier in the cycle. So, and she was not excluded from the study based on that. So it kind of confused the issue a little bit. This was a fairly small study, although 188 I think is pretty good. There's more data on the way. We know that many women prefer the IUD of having fewer, shorter, lighter bleeding episodes rather than longer, heavier, more painful periods potentially. It would be really, I think, highly likely that we would improve the uptake of highly effective contraception among emergency contraceptive users if the levonorgestrel IUD were shown to be effective as emergency contraception, either with or without the addition of the pill. However, the ectopic pregnancy that happened in this study raises an interesting question, which is, do we need to be careful to exclude women as candidates for this method if they report acts of unprotected intercourse more than 5 days prior to IUD insertion? And I would point out that this is actually a criteria for exclusion of placing an IUD in general because of safety issues. And then a second question, which is a different question, is given the data that we have right here, right now with these 188 women, are we ready to recommend this approach? We may or may not, depending upon provider tolerance of risk and patient tolerance of risk, we may or may not be ready to recommend concurrent insertion of levonorgestrel intrauterine system at the time of EC pills until more data are available. James, do you have anything to add for this part?
No.
Thanks.
So this is our next poll. So given, as Beth just discussed, given what's known about offering the levonorgestrel intrauterine system at the same time as EC, how comfortable would you be offering this option to patients? So the first choice is not comfortable at all, somewhat comfortable, or very comfortable. So please take a moment to answer this based on your assessment of the data that Beth just provided and how you would use it in your practice. Okay, so we have about an even split here between those who are not comfortable at all and those who are somewhat comfortable. And we've got 13% who are very comfortable. So as Beth mentioned, there are more data on the way. There are some active research programs working on this question right now. And we will share that information with you as soon as it's public. So our next and final topic before Q&A is ongoing use of EC. And we have the question is, can I take EC as often as I need it, even in the same month? So this is a question that might come up among your patients who are not on an ongoing method and are having unprotected sex fairly regularly within the same cycle. So our final poll, do you think it's okay to recommend that patients use EC pills more than once in a cycle if they need them? So answer choice A, no, EC pills should only be used once per cycle. Next, levonorgestrel EC, like Plan B one step, can be used more than once per cycle, but not ELA. Next, UPA EC or ELA can be used more than once per cycle, but not levonorgestrel. And finally, either EC pill can be used more than once per cycle. Okay, so we've got about 20% saying EC pills should only be used once per cycle, so we should not be repeating use of EC in the same cycle. About a quarter say that levonorgestrel can be used more than once a cycle, but not UPA. And then about half of you said that either EC pill can be used more than once in a cycle. So James, would you please take us into our final topic?
Thank you, Kelly. Okay, what about ongoing use of emergency contraception? First, let's look at the levonorgestrel. And here, there was a study of 330 women who were instructed to use 1.5 milligrams of levonorgestrel after each sex act for 6 months. And among women, I think this is supposed to be less than 35. There were 10 pregnancies per 100 women years of use, and the side effects were mild, but the conclusion is that it's really not effective enough for this to be an ongoing method. Well, what about ulipristal acetate? We don't have a pregnancy trial, but we do have pharmacodynamic study where 30 milligrams of UPA was used for 5 days or 7 days for 8 weeks, every 5 days or 7 days for 8 weeks. But it turns out that most subjects ovulated. The side effects were generally mild, so again, there's no safety concern, but it doesn't look like it would work well enough to be used for ongoing contraception. So the message is for patients. We would recommend the most effective method always as the top line, which is the copper IUD. There's no need to repeat a dose of emergency contraceptive pills within 24 hours. Don't mix EC regimens, that is, don't take a levonorgestrel one and UPA within 5 days of one another because they can counteract each other. And it's safe to repeat the same ECP within a cycle, but it may not be effective longer term. Having to use ECPs more than once per cycle is probably a good indication that a better ongoing method be found. So that brings us to, Beth, do you have something to add?
Just to say that in the same vein as the last best chance, we know just in clinical practice that we have clients whose partners sometimes do and sometimes don't use condoms. For whatever reason, they're reluctant and don't choose a more effective method, a more highly effective method. And for me, I think the other side of this coin is that it was sort of surprising to me that it was as effective as it was to use the levonorgestrel after every act of unprotected intercourse for 6 months. Of course, we don't know how often that was, but that it ended up being as effective as other coitus-related methods. So to not discourage women from using it if it's what they've got, and so I think that's that's something to just of course we want to help them get more protected and have a more highly effective method, but the safety and somewhat efficacy of using it repeatedly, I think a lot of women get into sort of being judged for using it more often, and to try and stay away from that.
Thank you, Beth. So we're going to move on to Q&A, and if you have questions, please feel free to type them into your question box. There are a few that have come in throughout the webinar, and I'm going to throw them to our panelists. One thing that somebody just asked, it would be nice to have citation information for these studies. All of these citations are available on each slide. You may not be able to see them depending on how your screen is configured, but these slides will be available on ARHP's website after the webinar is over. You'll get an email about that, and we have a full reference list at the end, so you will be able to find all of these studies and read them for yourself. So we got a couple of questions about providing contraception after EC, and I'm going to ask Beth to start with these, and then James, if you want to add something, please do so. The first question is why LNG is recommended if missed pills are the reason that a woman is seeking EC. I'm going to give you both of these questions, and then you can just go ahead and answer them. The next one is, can you please repeat in basic terms the pharmacology of why progestin-containing birth control methods lower the efficacy of UPA?
Sure. So I think that the main point of using levonorgestrel when people have missed pills or patches or ring is that they have an ongoing method of contraception. They've been using it. They want to get back to using it as soon as possible. They may be less at risk depending upon, of course, how long it's been since they've been off. And I think that's, that's where you get into the fine-tuning of it. Is it 1 day missed? Is it 2 days missed? Is it 4 days missed? That kind of thing. But essentially the idea that given their emergency contraception and help them get back on their ongoing method that's going to be more protective for them over time. And then, of course, that would be individualized depending upon the length of time that somebody had been off, but also the idea that if there is progestin, if progestin does block the efficacy of olipristal acetate, is the progestin-containing contraceptive that's in the person's system maybe still going to affect the ELA? The ELA then would mean that they would have to wait to get back on their method. So all of those things, I think, are part of that. And then the pharmacology is that, and James, maybe you can chime in on this too, but a very basic way of looking at how ulipristal acetate works is that it's an anti-progestin. And the initial worry was that, I think this is what happened, is the concern was that this anti-progestin might be powerful enough, because it has a long half-life too, to keep ongoing hormonal contraception from working for longer than what we wanted, which I think is part of why we initially recommended a 14-day backup method after ELA, because we were afraid that it would stick around so long that it would prevent pills or rings or patches from working. Well, in effect, the opposite happened, is that the progestin is stronger than the anti-progestin, and it blocks the activity of the anti-progestin.
James, do you want to add anything to that?
No.
Okay. A similar related question. You say not to mix EC regimens within 5 days. What if a woman has UPI today, unprotected intercourse today, and then again 3 days later? Should I repeat LNG with each act of unprotected intercourse, and what about UPA? James,
you can do either one. You can use levonorgestrel followed by levonorgestrel, or you can use UPA followed by UPA, which would be the more effective option. What you don't want to do is to mix them.
Okay. We have a couple questions about the question of efficacy and weight. James, why don't you take this one? Regarding the efficacy of EC and weight, some of the studies assessed the relation of efficacy with body weight and efficacy, while others used BMI as the metric. I strongly feel there is need for consistency and would like to hear your thoughts on the most appropriate metric, whether it should be body weight or BMI that we're talking about in assessing efficacy of EC.
Well, in the Glaser study, and also in the same was found whether they used weight or they used BMI. So the same result, that heavier women measured either way, levonorgestrel was less effective. When the label was changed in Europe, the company went with weight because they thought that many more women would know how much they weigh than would know what their BMI was. So that's why they chose to go with weight in the label.
Okay. Beth, do you want to say anything about that?
No, that makes it very clear. Thanks.
Okay, so another question. We had a few questions come in about breastfeeding, so I think this is an important thing to address. So one question is just looking for a point of clarification. Should it be no breastfeeding after 24 hours or 5 days? Another question says, did you say express and dump breast milk for 5 days with UPA or LNG or both? So Beth, can you just address these issues about breastfeeding and EC a little bit?
Sure. Well, I can, I'll take a stab at it. The selected practice recommendations, and I will do some further investigation into where and how and why the CDC panel of experts decided on 24 hours rather than 5 days. But our U.S. recommendations for use now do say 24 hours to express and discard for 24 hours after ulipristal acetate, after ELA. There isn't any need to express and discard after levonorgestrel. We have a very good level of confidence that levonorgestrel is safe in breastfeeding and is compatible with breastfeeding, and there isn't any need for concern with that. My guess is that you know, the ulipristal acetate is still relatively new. It takes a while for data to come in about breastfeeding. Studies are difficult to do because it's an area of such great caution that it often takes a while with any new drug to get the information that we need about safety and lactation. So for the time being, you know, this may change. We know that ulipristal acetate gets into the breast milk, as does levonorgestrel. We know levonorgestrel in breast milk is not a danger to a breastfeeding infant, and we don't yet know that about the UPA. So I think that's right now where the precautions are coming from. But I will check on that and try and get some more information.
Yeah, it's interesting because I've sat on the guidelines committee in the UK and in the US, and we come up with different recommendations. There simply are no data for UPA. However, one practical suggestion, whether you're using UPA or levonorgestrel, is breastfeed right before you take the pills, because that means particularly with levonorgestrel, then you're getting a longer duration since taking the pill before you have to breastfeed again.
Okay, we have time for just one more. We had several more questions. We're not going to have time for all of them. James, we had a couple questions about the mechanism of action of IUDs. One was just a comment. There is fear of using IUDs for fear that it is abortifacient. The other one says, please confirm mechanism of CU-IUD effectiveness as EC. It disrupts fertilization or implantation only, correct? No evidence of preventing ovulation. Can you just talk a bit about that?
Yes, the IUD, the copper IUD, is so effective when used for emergency contraception with only one failure in 1,000 women that it must be able to work after fertilization. Otherwise, it wouldn't be that effective. However, it doesn't. It doesn't. Insofar as we know, it certainly does not cause an abortion. It does not cause an attached embryo to unattach.
Okay, thank you very much. All right, thank you so much to James and Beth for a great panel today, and thank you to all of our participants. Before we end today's webinar, I just want to share a few reminders. You'll receive an email from Caitlin in about an hour containing a link to an evaluation. Your CME or Nursing CE certificate will be generated at the end of the survey. Please be sure to print the certificate before closing the internet browser. And if you have questions, please email education@arhp.org. We hope you'll join ARHP for another one of many webinars this fall, covering topics ranging from contraceptives to osteoporosis to HPV. For a full list of all upcoming webinars this fall, please visit arhp.org. And again, we had a few more questions. We will have these slides will be available on ARHP's website, including all of our references, our resources, our references that we cited in this presentation. And then we have some more resources here. Bedsider.org and nottolate.com are both great places to learn about emergency contraception. And finally, here are these are our references, and we have some resources from ARHP. So thank you very much, and look out for your email from Caitlin about continuing medical education.